get my recording. Okay, great. So I know you guys are, you know, still catching up on pharmacology and anesthesia, and then next week is going to be surgery. So they kind of all are big domains of stuff, but they kind of fit together in, you know, everything that we're doing. You know, they trickle in effect. So pharmacology and anesthesia, and then anesthesia to surgery, and then from there we have, you know, some other ones that you guys may be able to, you know, finish a little bit easier and then kind of go back to those other ones to work in as well. So I kind of did that on purpose, so we could give you guys time to go back and work on those things. And then we can always, you know, in our sessions, talk about those things over and over again to reinforce those areas. So don't worry too much, just keep working and plugging away. So today we'll talk about some anesthesia. I currently am uploading the one that we did from Thursday. It just takes some time to get it converted and then onto YouTube and then back to you guys. So with it being such a long session, it takes like a couple hours for it to convert over. So but it is almost done. So I will have that onto Moodle very, very shortly, probably before we are done here today. So, but we talked about some really good things and got even some of our anesthetic drugs taken care of. So what from this week, from anesthesia wise, do you guys have some questions on? And then we'll kind of go from there. Otherwise, I'll start going crazy with things that I find important. Parts of the anesthesia machine again. Okay, great. You can do that. Anything else? ECGs, yeah, of course. Yeah, calculating ECGs, awesome. And Jamie's like, yes, ECGs, of course. Great. Everyone has monitoring down pat, all of that, stages and planes, all that jazz, the very basics.
I would love to go over the stages. I'm really fuzzy on those.
Okay, yeah, great. Perfect. Yeah, we can do all of those things. Great. So let me share my screen as we start. All right, so we'll kind of start from that beginning and then we'll work our way down if that works for you guys. So when we talk about stages and planes of anesthesia, so when we do our stage 1 of anesthesia, this is when we are starting to do like our pre-medication, right? So we pre-med our animals, whether we're doing pre-medications at home, we do pre-medication at work, right? Giving them, you know, whether an opioid and or some sort of mild sedative. This is when they start just becoming drowsy, okay? So I just try to remember like a little type of term. And yeah, we can do some calculations as well. We'll try to get to that as well. So don't you guys worry. And so I try to remember just like little terms so that I can pick things out rather than going for like major definitions, okay? So stage 1 is just when they start becoming drowsy. So then when we get to stage 2, this is when we're starting to do induction on them, right? So stage 2 is something that we try to avoid a long stage in. And so the reason for that is this is when they have that excitement phase. Okay. And so if you have a long excitement phase, they can, what are some things that could be like a side effect of that excitement phase? You guys remember?
Is that emergence delirium?
Yes. Yes, absolutely. What are some other things?
They'll fight. They'll move. They'll fight. They won't.
Yeah.
It's hard to control them.
Yes, absolutely. Absolutely. And so when do we see like the greatest amount of excitement? Like with what type of induction?
Masking down.
Yeah, masking down. Absolutely. Or what is another type as well that's equivalent to masking down? We do it a lot in like cats. Induction chamber, perfect. Like the boxing down of cats, right? And so this would be probably our most dangerous way of induction, right? Because we don't have like an airway on them or anything like that. And so they could have, especially in this excitement phase, they're so excited. There's this fight or flight response during that time, correct? So they could have arrhythmias at that time. And we don't have a handle on them at that time to be able to evaluate them either. So we want to try to induce or reduce that excitement phase as much as possible. So this is where in modern medicine, because we used to box down or mask animals a lot, right? If anyone, has anyone been in the field for quite a while where we did this all the time? Or where you do this a lot even? It's okay.
We tend to do it on rodents because
Yes.
I moved to lab animals. So
Yeah, lab animals, right. We do that a ton, right? Lab animals is very different. We can't, I wish we could probably do something different, right? But we really can't.
exactly.
Yeah, lab animals, so different. But yeah, with masking down cats or dogs and stuff to that effect, we have now these wonderful ways of giving different cocktails to minimize the excitement phase, right? We try, that's what the biggest thing is that we're trying to do is minimize that excitement phase. So I know, I wish we could do that. Plus I know, Debbie, like you guys are probably anesthetizing a bunch of different rodents at a quick pace to be able to do stuff.
Exactly.
Correct? Yeah.
Yep.
Yeah. So it's much, much different. Awesome. So so when we have this excitement phase, and remember too, when they do wake up, they're waking up from their stages going backwards. So the way that they go down in their anesthetic event, they're going to wake up the exact same way, right? So we want them to have a nice smooth way of going down in anesthesia so that they wake up very nicely, right? Excluding huskies just do whatever they want, right? So they're most likely they'll have a nice smooth recovery too. But this way we know that they're going to have a nice smooth recovery. Okay. Okay, so excitement phase at stage 2. Okay, we want to try to minimize that. So stage 3 has multiple planes, as we know. All right. So stage 3 has plane 1, plane 2, plane 3, and plane 4. All right. So if we look at the planes, okay, what do you guys know about surgical plane level? What is our surgical plane level?
You want to be at plane 2.
Good, good, good. So we know that surgical, this is surgical plane. So this is our happy place, right? All right. So if we know that, now we can say, all right, if we have stage 3 plane 1, what can we do during stage 3 plane 1? What is our
Intubate?
Yeah, that's our intubation. That's our intubation plane, right? So there are definitely, you know, we have now gotten through our excitement phase, and we are now to a great enough stage where we can intubate them, and we have bypassed that excitement phase. But can we actually do surgery on them? Absolutely not. They would be like, ouchie, no, 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 right? So that is a great enough stage to be able to intubate. So we're at our happy place at stage 3 plane 2. And we'll get back to eye positions in a few seconds. So now, what about stage 3 plane 3?
They're getting a little too deep.
Yeah, they're slightly too deep, right? So they're too deep. All right. And so this is where I love eye positions. This is where I love when we have our technicians being super hands-on with our patients under anesthesia. And when we cannot rely too heavily on our monitors, right? We need to have our veterinary technicians inside the surgery suite, because we have to be able to monitor their stages and planes of anesthesia, because they can go really fast from stage 3 plane 2 to way too deep and close to death, right? So we're really balancing our patients during surgery from near death experience, essentially. So we have to be there to be able to have our hands on the patient. So awesome. Now, what about stage 3 plane 4?
Overdose.
Yeah, there's an overdose. It's way too deep, right? So overdose, way too deep, however you want to term it. And then what about stage 4?
CPR.
CPR now, right? Like we need to do some CPR. This is not good. Yeah, cardiovascular collapse, very good. Wow, way to be technical. I love that, right? So however you want to term it, like your animal is no longer with us. We have waited too long, right? So very good. So this is how I term it, just so that I can remember all of these stages and planes, rather than these super, super long definitions. So when we look at eye positions, because that's a huge part to be able to look at, because you're putting your hand on the patient and you are only given basically the head and maybe the front 2 legs to work with to monitor your patient, right? So of course, when they're drowsy, eye position would be, they're still looking at you, right? So nothing too crazy. Excitement phase, still the same. They're just looking at you. Intubation, now you guys get to see my amazing drawings. So intubation is that they're still looking at you, right? We don't necessarily need to look, essentially. Big difference here for surgical plane stage 3 plane 2, what is their eye position here?
Ventral, medial.
Okay, ventral medial, very good. So they're going to be looking here, right? And their little pupil is like down looking here, or their eyes like looking over here, right? So they're looking down at their nose, essentially. All right, so if they're too deep, what would be their eye position here?
They're looking right at you and they're very fully dilated.
Good, so they're pretty dilated, right? So this is constricted, all right? There's more dilation going on here. And then here, they're looking at you still with really dilated eyes. Just keeps getting dilated. And then here, it's fully dilated, right? Where you have no corneal at all. No corneal reflex. So then we talk about reflexes. So when we talk about in the reflexes of the patient of how they're lost for anesthesia. So for intubation, what reflex is lost in plane 1? So that
Swallowing.
good. So they lose their swallow reflex, right? But they're still going to have quite a few of their other reflex, or gag reflex, you can say, absolutely. So we'll call that gag as well. Oh, gag. All right. I cannot write this way. You would think by now I could figure this out. Okay. Now in plane 2, they also lose another reflex as well.
Their blink.
Okay, so there's one before that, but you're right on that level. There's one before that.
Ear flick.
No. What? Remember, we can't do surgery during plane 1 because they would be like, oh no, yeah, they're pain. So how do we check for pain? They're pedal. Very good. Very good. So pedal comes next. So their pedal reflex. And so remember, how to remember pedal is that we pinch their toes, and toes, remember we push our gas pedals with our feet. So they lose their pedal reflex, okay? So they don't feel that pain. Very good. So in plane 2, they could have, I always say, plus or minus palpebral. Because sometimes you'll have some patients that have a little bit of their palpebral and sometimes they don't. It just depends on the patient. So you're right on that one, the palpebral. Okay, and then same thing in plane 3. So you really have to rely on eye position on that one, okay? And then in our plane 4, what do they lose last? So we'll just say these for both. Corneal, very good. We don't want to lose this. Don't want to lose that. So those are important reflexes to know that we want to lose, essentially. The gag, the pedal, and palpebral, depending on the patient, right? But corneal, definitely want to keep. So awesome. Does all that make sense or make better sense? We always want to keep corneal for any patient. So even in horses and all of that, yeah. And same in, and it's going to be the same in like stage 4 and stuff. Same thing in people. So all right. So next, let's look at, let's see. You guys wanted to go over some, let's see, we had ECG stuff, calculations, and anesthetic machines. Perfect. So the parts of the anesthetic machine itself. So let me make sure. Okay, so when we talk about the anesthetic machine, let me see if I can find a really good picture really fast. So you guys can relate. Like it's like, you want to buy one? Nope, I don't want to buy one. Just want to find a good picture of one that's not like super boxy. So for our anesthetic machine, have you guys ever gone through like the way that it travels, the way oxygen travels through the anesthetic machine?
Yes.
Okay, awesome. Fabulous. So let me know. Oh, this one has a ventilator. No, it doesn't. Soda lime canister. This is kind of a weird one. Why did I pick a weird one? Beth, come on. I picked like a human one that is weird. Okay, maybe this one was better. Yes, it is. All right. All right, so tell me how you just want to go over kind of the parts of all of them, or do you want to go over how the flow is? Oh, both. Okay. Just like everything about. All right, perfect. All right, so everyone can see the sky up here?
Yes.
Okay, perfect. So, all right, so when we look at this sky, we'll see that we have 2 oxygen tanks here, right? And then remember too how in the video, it shows that in the lecture that I had, it says that when you turn on your oxygen each day, that you should be calculating out how much oxygen you have left in your tank for the day, or how many minutes you have left, so that you know if you should switch over your tank. So like say this one is on and working, and so if you don't have enough for the day, that you could switch over to this tank. So that's the reason why it's nice to have the 2 tanks going. So that might be something that we can work on too, if you guys have questions about that. So in order to have oxygen hooked up here, yeah, we can go over that formula, no problem. So in order to have these guys on here, they have to have what's called a yoke, which is right here, to be able to fit on appropriately. So it's not like you can hook up like a nitrous oxide tank to here, because they have a special yoke that is only fitting for oxygen. And same thing, if you had nitrous oxide yoke, you couldn't put oxygen on there. So yeah, that's the reason. It's like a key essentially to put on your gases. So when you have that, that's how you will turn on your oxygen. So this little tab up here, there'll be like a little wrench that goes with it, and you'll turn that on each day. The way to crank on the oxygen is this little device here, this lever to make this tighter and to put on your oxygen. So when would someone use nitrous oxide? Not much anymore. This is just, they used to use it quite a bit a long time ago. More often than not, if you guys have in your practice another type of gas, you might see maybe medical air. And so that might be something that you'll see. And I don't see it as often. I see it a little bit more often in like some specialty clinics or like universities, especially when they're using like ventilators and stuff like that. But I don't see nitrous oxide quite as much anymore. So yeah, but maybe some dental places might use it, but it's kind of, it's interesting to use because you have to mix it with oxygen as well in order to use it. So it's just a little bit different to be able to use, but we don't use it as often. So that was just an example, but good question. So when you have your yoke, so you have your oxygen there, then you'll have your tubing for your oxygen. So it kind of looks like they're missing a little tubing in here, but that's okay. It then has a pressure gauge, which is also probably hidden a little bit in the back. So that is the pressure gauge actually minimizes the pressure coming from the tank and makes it the pressure a lot slower, so that it doesn't blow your animal's lungs up a lot, because that pressure coming from the tank is really, really strong. So it minimizes that pressure down to about 45 PSI at a time. So it really brings down that pressure quite a bit. And so that pressure gauge is probably back here somewhere. So when that's coming out, it goes through that pressure gauge first. And then from that pressure gauge, it goes through that green tubing all the way to the flow meter. So when you get to that flow meter, it stops right there until you guys turn on that flow meter. And so when you turn it on with the little tiny ball that's in there, you turn it on and you are able to give just oxygen if you want. Or you can give oxygen, and then you can give, or you can turn on your, it looks like isoflurane there, oxygen and isoflurane. So there's no way that you can just give isoflurane. You have to be able to mix isoflurane with the oxygen, because isoflurane just comes in a liquid. So it needs to have some sort of gas to make it a gas itself. So when you turn on this this oxygen, it will then go through this little black tube right here. All right. And it will either go past the isoflurane, or if you turn on the gas if you turn on the vaporizer itself, it will go through the vaporizer and pull up the vaporizer and make it into a gas. It bubbles it up, and it will come out with oxygen and isoflurane. So the interesting part of it is that when you guys turn on this isoflurane, right? You're turning it on to a percentage, correct? So how many of you guys utilize isoflurane currently or have used it?
It's all our clinic uses.
Yeah, right? A lot of people use it. And same thing if you use sevoflurane too. Like it goes for pretty much any of these vaporizers, right? So say you're maintaining your patient on 2% isoflurane, okay? And you have your oxygen at 1 liter per minute, okay? So you have 1 liter per minute of oxygen, okay? And then you have your ISO at 2%. All right. So we want to know how much mils, so how many mils of ISO are given every minute to your patient.
Would it be 20?
You're so smart. Okay. But if you're figuring this out as a person who's like, I have no idea, how do I do this, right? So how you, and then also like how many mils of oxygen then per minute?
$9.80.
So what you then end up doing, right, is that we have to say, okay, so we are essentially pulling out our oxygen. And remember, our oxygen is going through the vaporizer and it's making a combination drug, correct? Just like we would if we were mixing a bottle of something together, right? Or a CRI. We're essentially making a CRI of a gas, correct? So we only have 1 liter of gas itself, and 2% of that liter is isoflurane, if you look at it that way, right? So if you guys know your conversions, you then say, okay, 1 liter equals 1,000 mils. 1 liter equals 1,000 mLs. And so 1,000 mLs per minute is O2, right? And then 2% of the ISO is, 2% of that gas is going to be isoflurane. So just like you said, 2% of 1,000 is 20 mLs. So you are absolutely right, 20 mLs. Correct? Oh, no, that's not right. It should be 200. Am I right? 200 mLs of ISO? Or is that 20%? Oh, see, I'm losing it. It's too early. 20 mLs, you're right. 20 mLs is ISO. Thank you, Michaela. You're like, no, you're crazy. Okay, 20 mLs is ISO. And then how many mLs then of the leftover is O2?
$9.80.
Good, 980. Awesome. So 980 mLs is O2. So just kind of understanding like how the vaporizer and the oxygen itself works by going through its course through. Makes sense? Super easy. So the more that you turn up, and then here's the other part, the more you turn up your oxygen, right? The more you turn up your vaporizer then, so say you have your, I'm sorry, the more you turn up your oxygen, the more concentrated then you are or overdosing or giving more concentration then to your patient. So then say you turn up your oxygen to 2 liters a minute, right? You're giving more isoflurane then. So keep that in mind when you guys are dosing out your oxygen. Do you really need to give that much oxygen? Or say you guys are going, oh, my patient's too deep. You don't just need to turn down your vaporizer, look at your oxygen level too. Does my patient need to have that much oxygen? You should do your calculation dose of your oxygen, right? We do have a calculation dose for that. So yeah, looking at both of those things. So does that make sense to everybody?
So what formula do you use for your oxygen flow?
Yeah, good question. So oxygen flow. So I am, yes, let me get rid of some of this. So I go off of the new stuff, the newest guidelines. So I go off of like the AHA accredited, or I'm sorry, the AHA's guidelines that came out last year. So for rebreathing, it is 20 to 40 mils per kg per minute, right? So you're going to have 2 answers for that. And then for non-rebreathing, you are going to have 200 to 400. Oh, I guess this should be mils. Oh, I did it. 200. Look at me. I am like, I need coffee. Mils per kg per minute. So I write this, but it should be like multiply, if that makes sense. So we can go over that stuff too. So it makes that really, I think it makes it a lot easier to remember now as well, just with formulas. But so yeah, I shared those guidelines with you guys too, if you want to take a look as well. So, but yeah, those are the new standards. It does have a minimum. Yes, thank you for that, Michaela. So it has a minimum of 0.5 liters per minute. So say especially for non-rebreathing, yeah, so it has, especially for non-rebreathing, you have to have it be at least 0.5 liters per minute. And many of our patients are so little, but we need to have it be at least 0.5 liters per minute because our vaporizer needs at least that amount to be able to work appropriately. So we need to make sure that we bump it up to that to make it work appropriately. Sarah, you learned it was 50 to 100 mils per kg per minute, or is that for induction? So yeah, in induction purposes, you can bump it up, of course. Typically what I do for induction is I just bump mine up to this area, and that's totally fine. You can do that. But these are the newest guidelines that we use. So of course, as you guys know, with medicine, things always change, right? And we always find new things that work, or that we find that are better or just more advanced. So that's why it's really, really important that we keep learning and finding what is the most high-end stuff. So with like the AHA guidelines, what is done with those things is that they utilize the people that are in the highest in our industry, and they do all this research to be able to put together these guidelines to give us the best of the best. And then, I mean, granted, there's like a ton of other things out there too that say these things as well. So it's just the newest stuff. So what will we need to know for the VTNE? You may have things that are calculations like this. And with any of our tests that we have, so even tests like VTNE, or I took the VTS test for emergency critical care, it is never about like getting the exact answer, right? It sounds really weird, but you find the best answer that is given. So you may have the exact answer, especially for math, and most of the time, but sometimes with rounding and all of that on your calculator, you don't always get the exact answer that they have, if that makes sense. And so you find the best answer that is given. Now, granted, the other choices are just nowhere near what they have, so it's not something that is usually an issue, but you give the best answer that is there, if that makes sense. So, but yeah, these are the newest ones that are out there. Plus, the VTNE always has the updated guidelines as well, and that's what they use. So, but just like I said, for like rounding, so like if you have kilograms and there's a decimal, and stuff like that, like we aren't always going to come up with the exact same answers, but they're going to be close, if that makes sense. So so yeah, these things are perfect to know as well. Okay, so and also you guys need to know past the VTNE, just to let you know. So think future as well. Okay, so we left off here at our vaporizer, remember? So we are going through the vaporizer. We have our gases we pick up, and then we're going through this nice process, right? And then every machine is a little bit different. Sometimes we go over to the back side of the machine. So this is why it's important to know your anesthetic machines. You have this like little connection point right here, right? So why is this connection point really important?
That's where you go from rebreathing to non-rebreathing.
Perfect. Yeah. So this is called the circle system if you're having a rebreathing system, right? If you don't and you are using non-rebreathing, you break off this system and then you go ahead and connect your non-rebreathing system. So with non-rebreathing, right, we break off that and then we're going to bypass this whole system. So with non-rebreathing, we're not going to have our soda lime canister. And why don't we need our soda lime canister?
You're not recycling the air to heat the patient.
Yeah, great. So yeah, it can just go straight into our scavenging system, which on here I can't find. So that scavenging system could be essentially it's something we add anyway, like it doesn't come with the machine itself, but the scavenging system could be the charcoal canister at the bottom, or you can have a scavenging system that goes through the roof and outside. So So yeah, absolutely. So if we follow the rebreathing system, we keep this connected, and then we go into our this little black box here that they have. Up on top here, you'll see there's two little valves, and we can't tell on our side here which one is which, right? But can anyone guess which one would be the expiratory valve that we would use? Or the inspiratory, I should say too.
Inspiratory is going to be the left one and expiratory is on the right.
Good. And why would you know that?
Because that's where the tubes get hooked up.
Okay.
The pop-off valve.
Okay, there's the pop-off valve. Very good. And then what's another thing that gives you that indication too?
The reservoir bag is on that
The
side.
reservoir bag. Very good. Very good. And most of the time the machines have the labels on it too. But yes. So that way you can know, so you're not like, oh my gosh, I forgot. It's my first day. I don't know what to do. But yes, you're absolutely right. Yeah. So the reservoir bag being on which side or the other is a good indication of where the expiratory is going to be. And then the inspiratory one is not where the pop-off valve is. So very good. And that's where it gets confusing because some machines are different than others. So you can't just be like, oh, on the right hand side, this is where it goes on the left hand side. So there's like a little, looks like a clock, right? But it's not a clock. It's a manometer. So what is so important about that manometer?
It shows how many pressures of oxygen they're getting in millimeters of mercury.
Okay, close. Not millimeters of mercury.
Water.
Yeah, so centimeters of water. I know, it's crazy. There's like millimeters of mercury everywhere else in our practice, right? For like blood pressure and all of that. But yes, the centimeters of water. Good. So when this has probably been ingrained in your brain, right? So if we are pressure checking for our patients, what do we want to go to pressure check our patients?
No more than 20.
Max is 20. Yeah, perfect. Okay, never over 20. Look. All right, so if you're giving a breath to a patient, same thing, right? You're giving a breath, you want to, close your pop-off valve, give a breath, go to 20, right? Sometimes I'll tell you that sometimes if you're working in critical care and you have them on a ventilator and they have like really bad pneumonia and all of that jazz, you actually do go over 20 to like expand the alveoli to kind of like dry up that pneumonia. But those are like, you'll go to like 25 or even sometimes 30. And it makes me super nervous because that's been ingrained in our brain, right? But those are like the extreme cases. So don't worry about that. But that's just like, that's like a side note. So just to let you know. But it always made me nervous because I was like, you can't do that. In large animal, though, when you give the breath, they actually go to 30 centimeters of mercury. Look, you almost had me say millimeters of mercury. So they go to 30 centimeters of water. So that's another like side note. Okay, so we give them a breath. They are taking a breath, and then they expire that air, right? And then where does that air or gas, all of that gas, go from there?
Soda line.
Okay. So, and not all of it's going to go to the soda lime, right?
It's going to get recycled back.
Yeah. So we have a few things, right? So some of that gas is not used during that time. So it goes into, your reservoir bag, right? There is a negative pressure gauge too. So just in case, you know, there's too much air. So we have to keep that in mind. That's one thing that people forget a lot, is that little tiny negative pressure gauge there. And then, yes, we have our soda lime canister that's there that that takes up that carbon dioxide, right? And then I'll get to your question in a second, Casey, but that's a great question. And then the rest, and then there's going to be gas that is then going to the scavenging system, right? We are gonna scavenge out the rest of that gas, okay? So, all right, so what do you do when the patient is sucking down the bag and it is difficult to give a breath? So yes, many times there'll be patients who are utilizing a lot of the gas that's in there, and it's hard to give them a good breath with, you know, not enough in the reservoir bag. So there can be a few things. So you, number one, could have too big of a reservoir bag that you're currently using. That could be it. And so you could change out your reservoir bag to like just a little bit of a smaller size. Number two is you could turn up your oxygen level. So don't flush your oxygen. Don't use the oxygen flush. That's bad. But you can turn up your oxygen, because then again, remember, when you turn up your oxygen, it will make the gas go through and then get into your reservoir bag. My first recommendation, though, is to get a smaller reservoir bag, okay, for your patient. Okay, the reason why we don't want to utilize the oxygen flush, or I should ask, why should we not use the oxygen flush valve?
That's a lot of pressure coming in that can actually blow up the patient's lungs.
Okay, good. What else? What's another reason? What does the oxygen flush valve do?
Dilute.
It dilutes the oxygen. Okay, absolutely. It dilutes it, but what? It's going to dilute it, but why does it dilute it? Yes, it delivers 100% of oxygen. So it literally bypasses your vaporizer. Yeah, great. So essentially what you're doing is you're like, oh, we just need to give a breath. So we're just going to shut off the vaporizer and, you know, just give oxygen, which that's something we don't necessarily need to do, right? We're just trying to give a breath. So that's such a great question. And it happens all the time. And I'll tell you, out of the people that do that the most is probably doctors. So they feel like, oh, the bag's not full enough, so like we'll just fill it up with, you know, the oxygen flush valve with it hooked up and everything. And I was like, you know what, you're not helping the situation here. Like go work on some charts or go find another patient or whatever. Like, we got this, don't worry. So like I said, that's why we really need to calculate out our reservoir bags and make sure that we have an appropriate size bag. And as we all know, like there's a range of bag sizes we can choose from. So it may be as simple as just, you know, going a size down on your reservoir bag. And it happens all the time. So that was such a great question to ask. Good job. Okay, so we went through our whole entire system on our anesthesia machine. What's really important is when you guys get into your new jobs or any job that you're at, is really checking out your anesthetic machines and getting to know them really well before you get your first patient into surgery, and just kind of getting familiar with how they work, so that you're not like jumping into a surgery and going, oh my gosh, where is each part on the machine? Okay, so great. A smaller bag is going to help because there's less dead space in there. So you're going to be able to, they're going to be able to have less room, and then you're going to be able to, it'll be able to fill up the gas a little bit faster. You can also turn up your oxygen flow just a little bit more. So also looking up at your oxygen flow as well. So yeah, kind of looking at both of them, but great question. Sometimes there's just a little too much dead space. But yeah, overall oxygen flow long-term is like a good idea too. All right, so any questions on the anesthetic machine?
Can you go over the non-rebreathing circuit?
Oh yeah, absolutely. Sorry about that. So our non-rebreathing circuit, let me find. And they have finally some nice newer ones that I like, but oh, I don't want that one. Okay, so what is another name, I should say, for
Bane.
yeah. Now I gotta find it. Ah. All right. Here we go. Such a pain to find. A good image. All right. And this is such a good one to go over because there are so many people that avoid the non-rebreathing like the plague. And they're so important to use for our little pets. So, all right. Oops. Okay. So everyone has seen these before? You're forced to use them in school?
Is that like
Yay!
a breathing bag?
It is the rebreathing. Yes, yes, absolutely. So these are probably, oh gosh, super old, right? Super, super old. And we have, so I picked a really old one, but there are new ones out there that are really awesome that actually have a manometer on it now. So this was like one of my like pet peeves is that this did not have a manometer before. But from my understanding is that there was a vet tech who actually like invented the actual manometer for it. So, so yeah, now we can buy ones that come. Yeah, so that's the cool thing is that like we are not, as people put it, you know, they always go, do you just want to be a vet tech, right? We don't have to be just vet techs, right? In quotes. We do a lot of really cool things. So, so yeah, you can buy ones that come with the manometers with it, and then they also sell just the manometer itself. So you can just attach it as well with it. So I encourage you guys to do it because it always made me a little nervous. Like how much pressure I put in there when I give a breath and stuff like that. So I'll put the link in our VTNE Prep crash course group page. So on Facebook, because they're really cool. So yeah, I'm using this old school one, but when you guys look at this, and especially when you hook up like the other tubes and stuff, the color code, like the color tubes always go to the scavenging system, right? So your scavenger altogether. So this part here goes to your scavenger. Okay. And so everything is a little shorter. Our non-rebreathing manometer is on the anesthetic machine. So actually your rebreather manometer is on the anesthetic machine. So essentially, remember, we are bypassing all of that when we unhook. So if you look at it here, oh, you have 2 manometers. So this manometer here is for your rebreathing. There's a manometer down here for your oxygen. So there's 1, 2. I wonder where your other one is. And then here's where you cut it to put your other manometer, or I'm sorry, your non-rebreather. And so then it branches off. So yeah, I wonder. Oh yeah, it's on the non-rebreathing circuit. Right. So yeah, if it's hooked onto here, then that's perfect. Yeah. So yeah, that was what I was talking about, is that, yeah, they now have that. So no, it's perfect. So this goes to the scavenging system. So whether it's the charcoal canister or, the scavenger that goes outside. And then we have our bag for the gases itself. Okay. And so then if you are looking for your pop-off valve is right here. So essentially you can close it so that, you don't have any gases going in or out. And everything can then, or I'm sorry, you can close it so that none of the gases can leave. And then that way you can give a breath going this way. And then none of the gases then can leave that way. If you open it, then gases can flow this way and flow this way. The patient gets hooked up right here, okay, on this elbow right there. And then our gases itself, so this is where it gets hooked up to the actual machine. So this tubing right here gets hooked up right there. So when the gases come in here, all the fresh gases get hooked up all the way to the patient right there. So that's why it gets fresh new gases each and every time right directly to the patient. And then when the patient exhales, all of those gases come back in and get taken out through the scavenging system. Now, this is pretty, wasteful if you look at it like on economical level. But for patient level and patient safety level, especially for our smaller pets, it's really a lot safer for those animals too. So that's why it's really recommended for the smaller pets to do. Any questions on that?
Do you have a picture of like the full machine? I realized I did really bad on my
Yes.
identification quiz.
Yes. So here's a full machine. So I know you came in late, so just kind of come back to it.
Did you guys already go over that? Oh,
yeah.
Sorry.
No, you're fine. All right. So yeah, we can. Everybody good on that? You want to move on? Minimum oxygen flow rate for non-rebreathers, they're both of them would be for 0.5 liters per minute.
That's something that confused me is that when I work with different anesthetic machines, I always got confused depending because I find that things don't always go at the same spot, so I got confused.
Yep.
Moving from practice to practice. Thank goodness I wasn't the anesthetist.
Yeah.
I was just in the room and thinking, God, I have no idea if I was the one in charge. No idea.
Yeah. I mean, and that's why, like, just kind of reviewing, and that's why kind of what I was saying is like just reviewing all of this stuff so you can follow the flow of an anesthetic machine so you can identify everything. So it's really important to know the flow of oxygen so that you can identify essentially where everything is before you start taking care of patients at every facility, because they're all anesthetic machines are slightly different. So, yep. All right. So we can now, I think, take a peek at our ECGs. So if we are looking at ECGs, when we start evaluating them itself, we know that we have these little tiny boxes here, right? And we can start with the fact that we have speeds when we evaluate them. So with that, there are two speeds that we typically evaluate them at. So our first speed we look at is 50 millimeters per second. And our second speed that we look at is 25 millimeters per second. Okay. So as you guys can see, there are a ton of little boxes, and then those little boxes are contained in these big boxes, right? So in the big box itself, across you'll see it's 5 little boxes, okay? So one little box, so one little box equals 1 millimeter. All right. And there are 5 little boxes in one big box. All right. So if we are trying to figure out across this whole thing how many seconds we have to be able to count for a beats per minute, that's our goal. How are we going to figure out how many seconds we have in the most easy way, I guess?
Do you count the big boxes across?
Yeah, we can count the big boxes. Great. So we basically say, okay, if there are 5 little boxes, right, in each box, and they're 1 millimeter in there, and we need 50 millimeters, say, in this, right? We can say that one big box that contains 5 little boxes, we're going to have to count 10 big boxes then, because 5 times 10 equals 50 millimeters, right? So in this, we'll have to count 10 big boxes. And then if it were 25 millimeters a second, how many big boxes would we have to count?
Is it 5?
Yeah, 5 big boxes. So it makes it really easy. So the first thing is that we don't even need to like look at the whole ECG itself. We don't have to look at the P, QRS, and T waves right away. We just need to evaluate like how many seconds do we even have to look at first to be able to see what the heart rate is, right? So what we do is we make sure, okay, on this ECG, do we have in the beginning 5 boxes that we can count? We have, I'll count this one. So We have one box here, so we'll start here. So one box, two boxes, that's two boxes, three boxes, four boxes, five boxes. So that's 1 second right there. And let's do this as a 25 millimeter per second, okay? And then this is one box, two boxes, three boxes, four boxes, five boxes. And then one box, two box, three box, four box, five box. One box, two, three, four, five. And then we have one box and then not a whole box. So we're not going to count any of this stuff at all. We can't. Okay, so when we look, we have 1 second, 2 seconds, 3 seconds, and 4 seconds that we're going to be able to look at for the ECG, right? So from the, okay, any questions? No? Okay. So from there, we go, all right, just like we do our heart rates on our animals. So say you guys are listening to a heart rate and you need to get a beats per minute, right? How do you guys figure out your beats per minute? How much do you listen to?
At least 30 seconds, right?
You listen for 30 seconds. Wow. Okay, and then you listen for 15 seconds. Okay. So, but if you listen for 15 seconds or you listen for 30 seconds, your end goal is to have how many seconds? You need what?
A minute.
You need 1 minute or 60 seconds, right? But then you have only, like 15 seconds or, 30 seconds or whatever, right? So that's how you figure out your multiplication factor of 4 seconds or whatever it is, correct?
Mhm.
Do you get what I'm throwing down at you? Okay, good. So we do the exact same thing here, right? It's just on paper. So technically, if you wanted to be super lazy and you wanted to listen for a heart rate on your patient and listen for 4 seconds, right? 4 seconds. What would your multiplication factor be?
15.
15, right? So you could do that. Say you have this crazy patient and it's like bouncing all over you, right? And you listen for 4 seconds, you just multiply by 15. We'll just give that example. So we do the exact same thing here, okay? So now we have enough information to go, all right, what is our formula per se to be able to get our beats per minute? So just like you guys do, we're going to count our R waves here, use our multiplication factor, and then we get our beats per minute. So same thing you guys do, except you guys hear those beats, right? So when you're hearing the beats, you're hearing R wave, R wave, R wave, R wave, R wave, right? So how many R waves do we have?
5.
5, awesome. So what's 5 times 15?
75.
75, very good. So our beats per minute are 75 beats per minute. So it doesn't matter if we're counting for our heart rate of counting what the ECG looks like. It just matters what the beats per minute are. Now we can evaluate this and go, okay, what does our ECG look like and what rhythm is it?
Not flutter, so that's good.
Why do you say that? Why do you say it's not flitter or whatever?
Because it's not like seesaw. It's not
Okay.
scary looking.
It's not scary. Good. Jamie says sinus arrhythmia. Why is it sinus arrhythmia?
Does it have to do with the T wave?
What's wrong with the T wave?
It seems like long and like tall.
Okay. It could just be really spaced out, but nope, the T wave looks good. So I thought sinus arrhythmia was when the heart beats sped up and down when breathing. You're right on that. Absolutely. Does it look like it's speeding up and down when breathing? Or does this look evenly spaced to you? Ah, yes, this is normal sinus rhythm. Good job. Yeah. So yeah, this is normal sinus rhythm. So look at it and say, okay, does the P wave look normal? Does the T wave look normal? I'm sorry, does the P wave look normal? Does the QRS look normal? Does the T wave look normal? Yes. Okay. Now, there's an issue with the P wave, right? If the P wave looks weird to you, then it's an atrial issue. If the QRS looks weird and abnormal, then that's a ventricular issue, right? So we cut all of our issues in half if we know at least that. That makes sense? Awesome. Let me see if I can find something weird.
Can you say that again with if the P wave is weird?
Yeah, if the P wave is weird, it's an atrial issue.
Okay.
If it is a QRS that looks weird, then it is a ventricular issue.
Okay, thank you.
Yeah.
Cracker, get out.
All right, let me find you another one that we'll do that will be fun. It will be fun. You'll love it. All right. Move all my stuff around that I have up here. Okay. So let's have you guys kind of work on this and then we'll kind of work together. So let's say this one is a 50 millimeter per second. All right. And we'll work on this kind of, we'll have you guys kind of start working on it and then we'll do check-ins. Okay. So, oops. All right. So let's go ahead and start. So 50 millimeters per second. How many boxes are you going to count for this guy? Big boxes. 10. Good. So 10 big boxes at a time. So you guys can go ahead and start counting and doing your thing. See where you guys come up, and I'll keep tabs. And remember, it has to be complete. The PQRS has to be complete in order to count it, if that makes sense. You guys have it? Okay. So Kelsey, where we get the multiplication factor is where we take 60 seconds, because we need a whole minute, right, to be able to get our beats per minute. So we have 3 seconds that we can only count rather than 60 seconds. So we have to take 60 seconds, divide that by 3 to be able to figure out how much to multiply it by in order to multiply our 9 R waves by in order to get 60 seconds worth of our beats per minute. Does that make sense? Okay, perfect. Melody, so if you count that last R wave, then you would get, yes, 200 beats per minute, but we actually don't have a T wave to count there. So that's why we just didn't count that one.
Ah, gotcha.
Yeah, not that you can really see much of a T wave, but
Hmm. I just saw the spike and I counted it, and then I was like, oh yeah, we don't see the rest.
oh, good. See, it's great to have things click. I know sometimes it takes me forever, and then I go, wow, why did I make that so hard?
So technically, we would have 9 R waves.
Correct. So we have 1, 2, 3, 4, 5, 6, 7, 8, and 9.
Got it.
It just didn't quite make it. Anyone else have any questions on this one? And then we'll move to rhythm. Okay, so rhythm. How does our P wave look?
Erratic.
It looks crazy, right? All right, good question. So what lead do we want to have our ECG on usually?
2.
Lead 2, very good, lead 2. So yeah, it gives us a nice electrical visual, right, of like our SA node to the AV node and all of that. So yeah, we like to be able to see that, but great question. Perfect. I know I always get really mad when someone changes it to something else and I don't see that right away. And then I start freaking out that my patient's like all screwed up. And then I just go, oh, it's on the wrong lead. Never mind. Great. So our P wave looks weird. Okay. How about our QRS? How does that look?
It looks uneven.
Okay. It looks, yes, there's like some that are higher than others or whatever, but overall,
Looks pretty stable.
okay, it doesn't look like any major craziness, right? Great. So we can now narrow down at least what probably is wrong here. So we could say, okay, it's atrial something, right?
Mhm.
Awesome. So we're half smart here, right? Half smart. So now we have to figure out it's atrial what?
Fibrillation.
Fibrillation. Very good. Why would it be atrial fibrillation?
It's going up and down erratically.
Good, good. So yeah, if you look at it like that, it looks much like ventricular fibrillation, except for the fact that the ventricular part of the stuff looks great, right? So it's atrial fibrillation. Look at you guys, you're so smart. I couldn't trick you. I love it. So atrial fibrillation, very, very good. Awesome. See, you guys got this stuff. And don't worry, we'll be continuing to practice ECGs as we go along. There'll be some additional like little quiz stuff and whatever. So this isn't the last you see it because, well, number one, ECG interpretation takes a long time. It's not something that you guys are going to be like, oh yeah, I got this. I can go and interpret ECGs forever. But knowing how to at least recognize, like, that's not normal. I need to either, well, number one, I need to go let my doctor know about it. And then number two, finding resources to like look stuff up or, you know, that kind of thing is a good thing. So I still am not nowhere near perfect at all the crazy things that you see. I could do obviously the basic things and find like, you know, second degree AV block and all of that jazz, but there's always something crazy and weird that happens with ECG. So you just never know. Great. So now we can look at some calculations, I think was our next thing people wanted.
Did we cover the plane of anesthesia?
We definitely did. That was our number one thing we did.
I will watch the replay.
Okay, perfect. Great. So what calculations did you guys want to go over especially? One more question. What is a base apex lead used for? Oh.
Is that for horses?
Well, I mean, those typically are done like cardiology aspects, like more advanced, more base apex lead. Yeah, and you're right. They do for horses. I'm trying to think of what else yeah, so they do that for more large animal in general, mainly horses. I'm just double checking to see if there's what additional they use it for, so I don't give you the complete wrong answer. Is that? Yeah, and I see that they use it on buffalo too. So yeah, I guess I would say large animal in general. But it does look like horses quite a bit. And there's a bunch of studies on buffalo for some reason. Interesting. All right, so equations like lidocaine, micrograms per minute. So CRIs you're talking about. All righty. Okay, so let me dig into my brain, try to come up with problems here. So we have a, oh boy, let me give a decent weight, a 92-pound dog who we're gonna place on an FLK. We'll give you that. I'll just get like crazy terms with you. So we're gonna place them on an FLK CRI. You guys are like, what is that? FLK CRI. And so fentanyl, lidocaine, and ketamine, right? He is currently on, LRS at, gosh, 325 mLs per hour. And bag has, no, I gotta make this smaller because otherwise it's just gonna be too much. 125 mils an hour. Bag has 875 mLs left. Stop. Let's see. Fentanyl dose is 4 micrograms per kg per hour, I believe. Sorry, I just want to make sure that I have this. Yeah. And concentration is 0.5. I should make this smaller. I'll just put it in parentheses, 0.5 mgs per mil. Lidocaine I'm trying to give you like actual doses, not like me being crazy and making up stuff. Lidocaine dosage, we'll do 100 micrograms per kg per minute. And the concentration is 2%. And ketamine, if you guys don't have Plum on your phone, you should have it. It's like literally the best thing in the world. ketamine, we will do oh, here. 0.3 mgs per kg per hour. And the concentration is 100 mgs per ml. All right, now you guys get to see my horrible handwriting. Okay, we'll see how this one works out because I didn't really plan all of this out. So if we're trying to figure this out really quick, so this is kind of how you get this kind of stuff in practice, right? So your doctor will say, okay, I want you to make up an FLK bag for your patient, and they probably won't even give you these. They'll probably say like, here are your dosage, and then you have to figure out what is left in your bag and stuff. So, and so when you guys are doing this, what is your first step in this process?
Mix pounds to kgs.
Yeah, you'll figure out your pounds to kgs, right? You're gonna have to convert everything, yes. So what is our conversion from pounds to kgs?
Divide by 0.2 or 2.2.
Good, so we take 92, we have a really big dog, 92 divided by 2.2. And what do we get for our kilograms?
41.82.
Good, 41.8 kilograms. Good. So now that we have our kilograms, what is our next step in figuring out this lung problem? Because we're gonna have to like fill in some
Convert.
blanks here. How much fluids? Okay, so we're on to fluids. Perfect. So with fluids, what can we do about the fluids in finding out stuff?
Find out how long that bag's gonna last.
Good, good. So let's see how long that bag's gonna last. So what do we do?
Divide the rate by the amount in the bag.
Good. Oh, I actually did that. Perfect. Look at that. So we take 875 then, right? So you take 875, divide that by the 125 mLs, and you go to find out how many hours you have left, correct? And we have 7 hours. Good job. So we do have in the problem here minutes, right? So we are going to have to figure out how many minutes as well. So we just multiply our hours times 60, correct? To get just how many minutes. So we're going to need to know both of these. So we have 420 minutes as well. Just to fill in our blanks. So we do all of this work because we're going to have to fill in the blanks for kilograms and hours, kilograms and minutes, and kilograms and hours, right? So now we have all of that information to plug in what we need for these 3 problems. How did I get minutes? So what I did to get minutes is I took 7 hours times 60 for 60 minutes per hour. Right? Yeah, perfect. Great. So now we just do one problem at a time, right? So fentanyl, then lidocaine, and then ketamine. So it looks really scary at first, but truly it's just 3 problems in one. So for fentanyl, we are taking 4 micrograms per kilogram per hour, and then we have the concentration in milligrams. So do you guys want to convert first the micrograms right away, or do you want to wait till the very end?
Right away.
Convert right away? Okay. So how do we convert micrograms to milligrams? Great. All right, so we have 1 microgram equals 1,000 milligrams, or is it that a microgram is smaller than a milligram? I think you have it backwards.
Smaller, I believe.
Yes, so 1,000, yeah, no, you're fine. 1,000 micrograms is 1 milligram. So yeah, milligrams are a bigger unit. So we then, good, we take 4 divided by 1,000, right? To get our milligrams. So it'll end up being, great job, Jamie, 0.004 milligrams here to convert it over. So it's a really baby amount of milligram. And then we're going to input our kilograms here because it says we need kilograms. 41.8 kilograms. And then we just need to put in our hours because it says hours there. So 7 hours. Right? So if we take all that info, how many milligrams do we end up needing for fentanyl?
.33.
I got 0.17.
0.004 times 41.8 times 7.
Oh.
I got something else. Okay, Roxanne and I got 1.17. Let's try not to round yet. Let's leave it at that, okay? So, because we still have to do our concentration, so I might change it just a little bit. So let's leave it at 1.17-ish milligrams, all right? So now we have to divide our concentration in there, right? So we have our concentration and we have to get milliliters. So we divide our 0.5 milligrams, and that's going to give us our mils, correct? So how many mils do we put in our bag? So divide that by 0.5. How many mils do we need in our bag? Yeah. So yeah, 2.34, right? But how much can we draw up really? 2.3. Awesome. Great. Look, you just did a CRI. Awesome. So let's figure out lidocaine. Okay, so lidocaine, do you want to convert the micrograms right away?
Yeah.
Okay. So 100. And then how do we figure out micrograms again?
You divide by 1,000.
Good. So for,
Oh, that was actually good.
yeah. So we're figuring out a dosage. So it's not necessarily like you're filling out, you're doing a dosage to get milligrams in the end. So it's our, like just how you're doing a dose for, you know, Clavamox or, you know, any other drug. That's why you're getting milligrams. If that makes sense. Okay. I know it seems weird, but yeah, you're just getting a dosing amount. Okay, so if we take lidocaine, so we have 100 micrograms, you divide by 1,000 to get milligrams. So you have 0.1 milligrams there. And then we're gonna multiply that by your kilograms. So 41.8 kilograms. And then times that by minutes, 420 minutes. That's what we had from before. So now, yep, 0.1. Oh goodness, I have a large number. Yeah. 1,755.6 milligrams. Okay. So how do we figure out our concentration for lidocaine? Okay. So that's the divide by 20. Okay. So the question was, how do we figure out our concentration for lidocaine if it's 2%?
Be 0.2.
So it's 2%. Okay, so you have a shortcut. That's great. But how do you figure out? I'm gonna push you guys.
2 divided by 100.
2% is 2 grams.
Oh, I love you. Yes, 2 grams. And then
Over
what?
100 mil.
Over 100 mils. Yes, very good. So it means that in your bottle, or how the bottle of the drug was made, right? It is 2 grams of that drug in 100 mils of sterile water, saline, whatever, right? The solute, right? So that is how it's made. Just like just how we mixed any of the drugs, right? It means 2 grams of that. So if we whittled it down slowly, right? So 2 grams, if you make it into milligrams, that would be 2,000 milligrams over 100 mLs. You then cross out the zeros you don't need, right? It then ends up being 20 mgs per ml, right? So yes, you're right. You can do your shortcut, moving your decimal over or adding a 0 behind it or multiplying by 10, whatever works best for you, like in practice. But it's really important to know what it actually represents, because you may get a question that's like, pick the best answer of converting 2% or whatever. And it might not be 20 mgs per mil. It could be 200 mgs per 10 mils or something to that effect. And so you need to know what that means or represents. Okay. Does that make sense? Did you guys ever learn that? Someone learned it. Awesome. Great. So don't forget it, because you'll make me mad, man. Okay, good. So we have that. Sometimes I have people that never heard of that, and I'm like, oh my gosh. Okay, so you're right. So we're going to divide that by 20 mgs. And then how many mLs do we get then? 87.7. Look, I gave you something crazy. I knew I would do that. 87.7 mils. That's a lot. A lot of lidocaine. All right. And our last one is ketamine.
Wait, I missed something.
So we have 0.3 mgs per kg per hour. So we don't need to do any conversions here, right? So thank goodness, that's an easy one. So 0.3 mgs times the kilograms, 41.8 kilograms, times the hours, so 7 hours. And so then we can just do our math.
I don't want any if I don't have creamer. I don't want any if I don't have creamer. Fine.
Fine, you don't want any of that? Fine.
I don't want any.
All right. Good, you got 87.78, 87.78 milligrams. And then our concentration here is 100 mgs per mil. So we divide that by 100 mgs. And how many mLs do you guys get? Good, so 0.87 mils, and we can draw up all of that. Now, if you left it in 87.78 mgs and divided by 100, what would you draw up? Yeah,
0.9.
well, you can, so you can draw up though 0.88, right? With like a TB syringe. I know it's super technical. So careful on your rounding. So don't round until the very end, or try not to. Look at my crazy. Not that it's super important in this calculation because it's like a CRI and you have like a big dog and all of that. But like, especially if you have a really tiny patient. So, awesome. There was a problem that talked about insulin syringes. Anyone remember that one? About how to draw that up? Yeah. Everyone.
0.2.
Yeah. So it was about ACE promazine, insulin syringes. You had to dilute it down to. And you guys were like, what the? Okay. So this one was about like you guys having a dose that was a super micro dose, right? And so sometimes you'll have a dose where you have a patient that ends up with a calculation that, like, say you had the ACE promazine. And your calculation ends up coming out to be 0.008 mLs that you're supposed to administer to them. Or maybe I can make it, actually, I think it ended up being 4 for that one, right? You're supposed to administer that one, that much medication, okay? So obviously we can't do that, right? So how were we supposed to be able to do that? That was the first part of the question. So as we know, ACE promazine is 10 mgs per mil. So what we can do is we can take our drug itself and dilute it. All right, so you could have said, let's dilute this drug by taking 1 part ACE promazine and 9 parts sterile water, which could have been 1 ml of ACE and 9 mLs of sterile water, and put it in a sterile container, right? And then you have now recreated a drug that used to be 10 mgs per mil into 1 mg per mil? Does that make sense? Yeah. So this happens all the time, all the time. And then, so your answer then would end up being, because you have now recreated this to take out a 0, you now have your animal getting 0.04 mLs. Oh, now we can actually administer something like that, right? That makes it more workable. So if we do that, now we have to talk about the insulin syringe part, right? So how do we give a U100 insulin syringe? How do we draw that up by using, if we have a TB dose, right, ml unit, what would be the amount we would give if we use an insulin syringe? Okay, good, 4 units. So essentially, an insulin syringe that's U100, 100 units means that if we look at our regular syringe that you guys are used to, like the TB syringe, 1 ml equals 100 units. All right. So it makes it really easy to be able to utilize insulin syringes if you need to. Okay. So in this case, we would use 4 units. Does that make sense? So especially when you guys are dosing out like little tiny things, exotic patients, especially if you guys are into exotics, sometimes you have to like kind of make your own dosing and stuff too. Or if you're working with little mice, I'm sure you have to, you know, dilute down drugs or use compounders quite a bit more. They do that a lot. So I wanted to make sure to explain that. How would you set that up if we wanted to cross multiply it? Oh, I see. Okay. So, okay, I see what you're saying. So if you did 1 ml over 100 units equals 0.04 mLs, I would say. And then this would be X. That would be your cross multiplying. Yes, no problem. Great. Any other questions as of now? I know we'll have a ton of additional math and stuff that we'll go over, and a bunch of fluid math and stuff too. So yes, and KCL problems, absolutely. And I will, there's some older study hall ones too that I will open up for you guys as well on Moodle, that you guys can even take a peek at, that we've gone over like KCL problems and stuff too. If you want to watch, that are really good. I have a ton on YouTube that you guys can play with as well. Yay, good. Yeah, CRI problems are really not too bad. They just take a little bit extra time to do because there's like just multiple problems within it. So you just have to take your time with it. So can you go over the other gas tank colors, please? Yes, absolutely. So gas color tanks that you may see. So let me, goodness, find room. So, oh, look, we lost our X in there. Okay. So I'll just put it here. Okay. So when we talk about gas color tanks, so if we're talking oxygen, like those gas color tanks, you have, so remember oxygen, right? What is our oxygen gas color tank?
Green.
Green, yeah. And then let's see. Well, nitrous oxide, because that's fun. Nitrous oxide is what? Think of like Fast and Furious, even though the Fast and the Furious was like super long ago and I'm dating myself and whatever. Not purple. Now you guys have to watch the Fast and Furious. Blue, yeah, blue. So that was nitrous oxide. You can put it in your car, makes your car go faster. It's laughing gas. It does so many things, right? It's really, really fun. But it's also super potent too. So, okay, medical air. Colors medical air. Yellow, yeah, yellow.
What's the difference between medical air and like regular air? Like your oxygen?
Yes, so the oxygen concentration, absolutely. So your medical air is going to be is closer to like our normal air that we breathe. So what's our normal oxygen concentration that we breathe? 21%, very good. So it's going to be more towards that. It's just obviously in a tank form, it's probably a little bit higher in oxygen, but it's definitely, we don't want it to be as high, 100%. Why don't we want people at 100% oxygen concentration for so long?
Get too lightheaded?
Yes, but there's a reason why. Oxygen is destructive. Yes, it can be, but why?
Is there such a thing as having too much air?
Having too much, you have to have air, but it takes electrons. Okay. But what is it called? Like, what is it called of why we can't have too much oxygen? Oh, too much, I should say, too much pure oxygen.
Because it's carbon dioxide that actually stimulates us to breathe.
Good thought. It's harmful to tissues. Good. Harmful to what specific tissues?
Like the lung tissues?
Lung tissues. Very good. Very good. But why? Alveoli, good. But why? What is it called? Oxygen.
Oxygen poisoning. I don't know.
Yeah, that's one. That's one, yeah.
Actually? Wow, okay.
Yeah, oxygen poisoning or oxygen. It starts with a T.
Toxicity.
Yeah, toxicity. Very good. Isn't that crazy? You can become like have toxicity from oxygen, from too much oxygen. So yeah, people that have too much supplemental oxygen can have coughing, trouble breathing. They can even die from having too much oxygen for too long. So
how is that even possible? I don't get it.
yeah, I mean, it causes damage to their lungs. And so we have to make sure that they are able to breathe other types of, because they can't just have oxygen, they have to have other gases as well to be able to exchange, like everyone said. And their body just really starts shutting down. Like they have renal damage, they have liver damage, they can have adrenal effects too. That happens pretty quickly. And it can change a bunch of parts, like all different aspects of their body itself. So it changes, just the full effects of just how your body is functioning. So we have to be really careful. So being on pure oxygen for more than 24 hours is just not safe altogether. So that's why we have to make sure that they are not, if they are on a ventilator, we have to switch them over to some sort of type of medical air. So yeah, if you have, if you guys are doing like any type of ventilator, then having medical air is really important. I'm just looking really quick to see if there's any type of what the concentration of medical air is. Oh, it says that medical air concentration is somewhere between 60% to 40%. So, but it's still better than pure oxygen. So that's good. Great. So then if we're talking about like vaporizers, right? So what is you guys know isoflurane, right?
Mhm.
What color is isoflurane again?
Label is purple.
Purple. How about SIVO?
Yellow.
Yellow. And then desoflurane.
Blue.
It's like a light blue.
Light
Good.
Baby blue.
Teal color.
And then
Yeah, it's pretty. It's a pretty blue. How
Mm.
about halothane?
Red.
Red.
Red. This is an old guy, right? He's from like 1956 or something like that. So he's old.
And
I
that's
say
just the
that
label, right?
I say that because my dad was born then, so I can say he's old. And let's see, what else are we missing? Any big ones? I'm trying to think. Those are like the big ones that you should know. What do you guys have?
Nitrogen.
Nitrogen. Well, we have nitrous oxide, so. Or are you talking about nitrogen like liquid nitrogen, or are you talking about something completely different? Or are you talking about nitrous oxide? Oh, liquid nitrogen. Okay. What is liquid nitrogen then? I mean, it's not something that we utilize as a.
Isn't it really cold? They use for like freezing stuff.
Yeah. So yeah, we can use it for a lot of. We use it for like taking off, like little tiny messes or stuff like that.
You use it like skin tags or like wart, eh?
Yeah, definitely. Yeah, cryo pens, stuff like that. Yeah. Oh, I see what you're talking about. Yeah, the black nitrogen tanks for like your surgical drills and stuff like that. Absolutely. Yeah. So that's a little bit different, right? So those types of things, of course, are not necessarily patient related, but for your equipment. So absolutely. But yes, the nitrogen tanks, those guys are black. So I was like, what are you talking about nitrogen? But no, absolutely. And yes, so liquid nitrogen, that's fun. I've helped with a few things with that as well, and they're really cool to be able to utilize for. Cryo pens are very similar to that as well. So no, that's great.
They use it a lot in artificial insemination for large animals.
Yes, very good. And you're right, in large animal, they use that a lot. Also, same thing for if you work at a lot of reproduction places for, I guess for like dogs, like for breeding and stuff too, but especially in horses and stuff for artificial insemination, you're absolutely right, they use that. So if you guys are lucky enough to be able to see that at some point, just to see what it's like, it's interesting. It's interesting stuff. So you help with, see, we need to follow you around, Jamie, too, just to see what it's like. I know, it'd be fun. Awesome. Great. So yeah, those are like the main ones. I should put nitrogen on here for you guys. Nitrogen black. Just for thoroughness. But yeah, those are kind of the main ones. Any other questions that you guys have for now?
We're talking about the labels, but what's the actual color like of the fluids? Is it all like transparent?
Yes. Yeah.
Okay.
I know it'd be really cool if they were different colors, but no. Can we do a dehydration problem? Absolutely. So okay, so say we have an animal who is 46 pounds and they are 8% dehydrated. They vomited 2 times 3 tablespoons. And our doctor wants to, DVM wants to correct over 16 hours. Okay, so we need to figure out dehydration, ongoing losses. Oh goodness. Ongoing losses, maintenance, and then put those all together. So put them all together and figure out mLs per hour and drips per second. Okay, and this all has to be in a 16-hour form, right? Rather than 24 hours. So our first go-to is figuring out dehydration. All right. So first we need to figure out our patient's dehydration. So what's the dehydration for this guy? So, oh, I'm sorry, what's his KIGS? Sorry.
20.9.
Good, 20.9 KIGS, great. And then how do we do the formula for this?
Is it kicks times dehydration percent times 1,000?
Great, great. So we change our percent to a decimal, so it'll be 0.08, right? And then we multiply by 1,000, and that's going to give us our mils for this one. So we have
80 mil.
Is that what you guys all got?
Yes.
Awesome. So yeah, we have one part of our problem done, right? So now we have to figure out ongoing losses. So ongoing losses. So this is where we need to know our conversions. So our animal vomited 2 times, right? And our animal vomited 3 tablespoons. So how many mils are in a tablespoon?
15.
Oh, 15. Very good. So 15 mLs. So if we do this calculation first, so 3 times 15 is
45.
45 mLs. Good. And then we take 45 and multiply that by 2. We get
90.
90 mLs. Great. So now we know our ongoing losses right there. Great. All right. So now we're going to do maintenance. All right. So if we're doing maintenance, how do we figure out our maintenance for this pet?
2 to 4 mL per kg per hour.
I'm sorry, what did you say?
2 to 4 per mLs per kg per hour.
Okay. So that's one way. What is like our official
Like 5 mils.
Close.
Mhm.
What's the official formula we go off of?
Is it 132?
Yes.
You do the not the division, the other one. What's it called? It's kilos times kilos times kilos.
Yeah.
Then that's
The
part of
square
it.
root. The square root. Right. Yeah.
There
Yeah.
you
Yeah.
go.
Yeah. Good. So we used to use pretty frequently 60 mils times kg per day, right? A lot of people use that. You guys are correct in saying, yes, we could, as our cheat method, do 2 to 5 mils per kg, which would be on our hourly. But our official one, right? There you go. Our official one, very good, is what's in the chat there. But how we would do it in our calculator to make life easier is to do, you take your parentheses, you do 20.9 kilograms times 20.9 kilograms. It looks really weird. Times 20.9 kilograms. And then you take that, you get your answer there. You square root it, and then you square root it again. All right. You don't have to press equal on this part. And then at the very end, you multiply that by 132. All right. So that's for a dog. For a cat, you do the exact same thing. But at the end here, what do you multiply by?
80.
80. Okay. So the reason why we have this now instead is that this covers actually more of an accurate fluid rate because it's more of a body surface area versus just based on kilograms or a weight area. So it's just a more accurate fluid rate that they say. Okay. So yeah, just to kind of keep you guys updated on that new formula that we use. So yeah, let's try that. So I'm gonna take this away so we have space. All right, so let's try to do our maintenance for this guy, which is gonna be per day, okay? So 20.9 times 20.9, 20.9. All right. And then okay. So what do you guys get for the day? Is that what you got, everybody?
Yes.
Okay. So since we are only going to need for the day, I'm sorry, we're not going to need for the entire day. We only need for 16 hours, right? So we kind of have to work a little backwards on these. So we're going to have to go back to an hourly rate on our maintenance and then multiply by 16, if that makes sense. Because for maintenance, we only need 16 hours worth. So we have to take our 1290, divide that by 24. And our hourly rate is actually 53.76, but mils per hour. And then I'm going to multiply that by 16 hours because that's how much I really need. And my total is actually 860 mLs total. Is that what you guys got?
Okay, you lost me there.
Okay. So what
Where did
Oh,
you
just
get
found it.
57 again?
So this total is for 24 hours, right? And so I only need, though, 16 hours worth of maintenance fluids because I'm correcting this patient's fluid rate in 16 hours. So I don't want to give him his total amount of maintenance of 24 hours in 16 hours. So I have to work my way down to get just 16 hours worth. So I took that 24 hours worth and divided by the 24 to get his hourly rate. And then I multiplied by 16 to get 16 hours worth of his fluids. So I know how much he's going to need for 16 hours versus 24 hours. Does that make sense?
Got it.
Okay. I know it seems really weird. So now we have all three things that are asked, right? All three things. So we just add these guys together. So we take 1672 mLs plus 90 mLs plus 860 mLs, and we add those guys together so that we can find an hourly rate. So, and we have 2622 mLs. And so that's our total that we are going to need for 16 hours. So how do we find an hourly rate for this guy?
Divide by 24.
Okay.
No.
We need it for 16 hours though.
Divide by 16.
Or only
Good.
16, so divide
Yeah.
by 16.
Yeah, divide by 16 hours. Perfect. And then once the 16 hours are up, he's hopefully going to be rehydrated and we can move him just to his maintenance rate, right? So we're just correcting his fluids. Good. So we divided that by 16. And what do we get?
164.
Good. So yeah, we have 163.87. So let's just go with 164 to make our lives easier today. mLs per hour. Awesome. So say we have our 164. All right, so now we have to do drips per second. So everyone loves this part. 164 mLs per hour, right? Okay, so how do we figure out drips per second?
You need to know if you're using a macro or a micro.
Great,
set.
great. Before we do macro or micro, how do we change our hours to seconds?
Divide by 3,600.
I love you for that. Yeah, so why 3,600?
3,600 seconds in 1 hour.
There's 3,600 seconds in an hour, right? So how do we know that? Just like a trivia question you learned?
Yeah. Because
Two
Beth,
times 60.
Stop it. You didn't learn that. No. So the way that we learn that, right, is that, yeah, so there are 60 minutes in an hour, right? And then in 1 minute, there's 60 seconds, correct? So that times that equals 3,600. So that's how we figure that out. There's a meaning to everything, right? We just don't like memorize something. That's silly. Okay, now we can work on our macro or micro set. So what's the rules for macro micro?
Is it more than 100 mLs or less than 100 mLs?
Okay, that was one theory.
I think macro is 15, micro is 60.
Okay.
And then you're doing it according to the weight.
Okay, according to the weight. Perfect. So 60 drips per second. Okay. So the old theory was how much fluids you're giving, right? But we need to go off of weight as well. So macro set is for animals over what amount of weight?
7 kilograms.
Good, 7 kilograms. Micro then would be
Under 7.
good, under 7 kilograms. Okay. So, and reason for that too is usually your animals over 7 kilograms are going to be getting higher fluid rate as well. So it kind of fits in that. But we need to kind of make sure that we are fitting weights over fluid rate itself. So great. So this patient, are they over 7 kilograms or under?
Over.
Over, good. So we're going to use a,
Question, Beth.
yeah.
What about your obese patients? Whether it's a dog or a cat.
It kind of doesn't, so, I mean, it just it depends on like how obese, but it doesn't truly depend too much on that because your fluid rates are kind of go along with it. And yeah, I mean, it's just based on your own gut, I guess, on that, you know, like if they're right on the line, always go up, I guess. So it's like go to the macro. But yeah, I mean, it truly is not that big of a deal in
So
that
we don't
case.
need to follow it kind of like the tidal volume.
Right, yeah. Especially for surgery wise, like if you are nervous about whether or not you're going to go macro or micro, like go macro, because if in case like something may happen and you need to like bolus fluids or something like that, it's better to have a macro set versus a micro set. So okay, so this guy is a macro set, right? So we are going to put in our 15 GGT. Oh, why did I put seconds? That's crazy. This is mils over mLs, right? So this way we cross out our mils and we end up with drops per second. And that's what we're looking for, correct? So now we know we're on the right path. So we can do our math here. So 164 times 15 divided by 3,600. Ooh, and we get a weird number, which is great. I love that. So we end up getting 0.68 drops per second. Awesome. Now comes the fun part. How do we figure out what our drips per second are?
Times 10.
Okay. And then we still have a decimal. So then what do we do?
You either round up.
Ooh, but that doesn't give us that changes our fluid rate.
Oh,
So
you do the
Well, I got 7 drops per 10 seconds.
Okay, but that means you're rounding up. So is there a way to find an actual like
you do trial and error.
trial and error, yeah. So can you find a number that's closer that you're not having to round as much?
You do times 2.
Nope.
Times 3 gives you
Good.
2.04.
So you multiply by 3 seconds.
Mm-hmm.
And then what do you end up getting?
Got 2.04, so I guess you can put it to 2.
Yeah, 2 drops per 3 seconds,
For 3 seconds.
right?
Mhm.
It's a little bit less rounding than going to 7 drops per 10 seconds. Now, in this case, it's not as big of a deal. So it's just better to get in the habit of trying to find a closer answer. But in cases where you may have like, a smaller pet and you get answers like, oh goodness, 0.33 drops per second. Then what do you end up doing? So you just have to be, or even.
Would you just put like 3 instead of 3?
You just have to be cautious of like how you guys change your answer.
Okay, where did the
If it's
3
like
come
this.
from? Do you always use the 3 seconds?
No, so you basically, I say, you have to know a little bit of what decimals and fractions are, right? So, or I say just play with your calculator. So start trying to figure out, okay, if I multiply this decimal by 3, is it going to get me close to a whole number, right? So sometimes if you know, okay, 0.66 equals 2/3, that's pretty close to that whole number. And I'm not having to change my answer that much, right? And I'd rather go a little bit lower than a little bit higher. So to avoid fluid overload and stuff like that. Now in this case, it's not going to be that big of a deal, but I kind of just wanted to show you guys that rather than continue to teach you guys, you just multiply by 10 all the time, because it does change your fluid rate, especially with some smaller pets, quite a bit at times. So just be cautious, and we'll probably do that with a lot of our problems too, so that you guys kind of get used to looking at it, that you don't always have to do drip rates that are multiply by 10 or stuff like that. So you get a lot better with it. So Melody has practiced a lot and she just did it awesome. So good job. Any questions on that?
The funny thing though, the last part, I'm like, yeah, I got it. The first part, I always get stuck at that. So until the very end, I'm like, I know what to do. The other parts, I'm like, ah.
No, that's good.
Struggling
And
with the
most times now you guys have fluid pumps, so it's kind of funny we still do it. But sometimes you'll work at practices that you run out of fluid pumps and we still have to do it. Or if the power goes out and your fluid pumps aren't charged, then we have to do drip rates. So you just never know when you need it. So
Are those actual like on the VTNE, they're gonna give you multiple questions with kind of like that, or are those just like best questions?
you never know. You just never know. Do you know the reason why we are supposed to use the square root thing for maintenance fluids? I never learned that before. Yeah, so the reason why, again, this is, honestly, it's not, I would say, semi-new, but it's not. It's been out since 2013, right? But it is based on body surface area. So there are drugs out there that are based on body surface area too. So if you guys look at number one, any chemotherapy drug is all based on body surface area. If you look at dexmedetomidine, it's based on body surface area. That's why you guys are probably using a chart to do it, because a lot of us, I shouldn't say me, but I worked in oncology, so we did everything on body surface area. But a lot of people don't know how to calculate body surface area. And so these formulas were created that are a better understanding of what body surface area looks like for each species, so that it is more accurate. So same thing with how the 132 and 80 came up with. So it's a better understanding of that. So yeah, I can't begin to tell you like why you guys didn't learn that. It's just a matter of educators keeping up with what is going on and new within the field. Unfortunately, there's no material that's given to schools to say this is what you have to teach. It's just up to all of the educators to keep up with everything, which is kind of crazy.
Do they have like educator summits? That would be a good idea.
Do they have that? They do have one, yes. I do lecture at them.
Interesting.
I'm supposed to lecture at one coming up, actually.
What's the topic?
Oh, goodness. The topic is Harkness teaching, or Harkness learning, I should say, which is basically, it's just kind of like how we do stuff in a sense, but there's so much more to it. But how in classroom setting, it's the way that I did some education, but essentially teachers in the classroom don't actually talk as much, but it's basically where students are doing most of the talking and the teacher is making sure that students are the ones who are participating and collaborating together so that everyone is learning rather than the teacher just giving out the answers all the time. But they sit in like a table setting every day rather than almost like lecturing. So, and it's more inclusive and all of that. So, yeah. So, I'm hoping that more educators kind of pick that up, which would be nice. So, yes, and it's the inverse of the 3/4 is the square roots and the kilograms times kilograms times kilograms. You're right with the square roots. Absolutely. All right. So any other questions for today?
Did
We
you guys
will-
already go over rebreathing systems already?
Yes, we did. So yeah, I'll post the this recording for you guys to kind of go over that. So
Cool.
yeah.
Awesome.
And then of course we'll spill over a bunch of stuff too for you guys for next week as well. So anything that you guys think of and whatnot, we will go over a bunch of it next week as well. Because surgery, I know there's some stuff, but we'll go over a bunch of it next week. Make sure you go over your instruments too. So.
Question, Beth. Did we
Yeah.
go over for I see in our list we have what you do for each complications.
Mhm.
Did we go over that?
We did not. That might be something that would be good for next week. So let's go over that for next week.
Okay.
Yeah.
Cool.
Keep that noted for sure.
Oh, another question. For like the blood work that we do in clinic, like each clinic they have like different machines.
Yeah.
Can we go over that at one point? I don't know if it's.
Yes.
I don't remember if it's actually in the course or not.
Yes.
I just know that in school I learned only like 2 machines, and then in practice I was like, oh, a bunch of new machines. I have no idea what these do or how to use them.
Right. Let me find this exotic book thing for you. I have one in my phone. Hold on. Oh wait, here. Okay. So exotic animal medicine for veterinary technicians. There's a 3rd edition by Ballard and Ryan Cheek. It has a really cute sugar glider on there and an African gray and a little tortoisey thing and a fish on the front. The sugar glider looks really cute, but I'm not buying it. It's probably crazy. But I've heard really good things about it. And I know that I just had a person reach out to me from a tech program asking me about it. So that's the one I recommended to them.
To look for the different like anesthesia machines and all that?
Just
like,
exotic
blood work.
animal medicine in general. There's a bunch of stuff in there for it. So
Okay.
yeah, my exotic medicine book is like super old, my initial one. So that's the one I ended up going with. So, and then there's also a clinical laboratory medicine book as well, if anyone wants that. So.
Did we go over the sign of anesthesia overdose? How to correct that?
Yes. Yeah.
Yes, also? Okay. Cool. And in this session here?
Mm-hmm. Yeah,
Okay.
in the beginning.
I'll make sure to watch the replay.
Yeah.
Right.
Awesome, everyone. Well, we did a lot today. So great job, guys. You guys did a really fantastic job. So yeah, I'll get this uploaded for you guys today, and then get the other one I'll get uploaded right now. And keep doing a great job on Moodle and everything. You guys are doing great. And go back and take the other stuff as you go, but you guys are doing fabulous. So but yeah, we'll keep talking about stuff for surgery for next week, anything that we didn't cover today. So take notes on what you'd like to have covered. But yeah, have a great week. And I will see you guys next Sunday, and we'll go from there. All right.
Thank you so much, Beth.
Of course. Take care.
Thank you. Have a
day.
great week.
You
Have a good week,
too.
everyone.
Bye, guys.
Bye.